You know, we're growing and growing, and that's wonderful because there is a need out there. There's a need with so many seniors. Obviously, I'm part of the baby boom generation, and we're getting up there, so there's more and more of us all the time. Denise did a great job of introducing me, and I thank her for that. But I think most of you maybe know me or recognize me to see me, but not know exactly what I would do. And so talking with Denise, she said, you know, talking about healthcare advocacy would be a great thing to do here at Coalition, so that's why I'm here. So I want to start with a little story. It was Dr. Bloomfield who was getting extraordinary results with arthritis. And Sally was having some problems and decided, well, I should go see Dr. Bloomfield, see if he can help me. And so she went and she checked in at the desk and she sat down and the waiting room was full of people. And while she was sitting there, this little old lady was called back. She got up, almost bent in half, struggled to walk back to go to the exam room. And so I thought, oh, that poor woman, she must have terrible arthritis. And it wasn't 5-10 minutes, and she came walking out. She was standing erect. She had a smile on her face. And Sally was just astounded. It was a miracle. What happened? And she couldn't stand it, so she had to go up, and she said, excuse me, ma'am, I know it's none of my business, but what did Dr. Bloomfield do for you? It was like a miracle. You're walking so much better. And the older lady looked at her, and she said, well, he gave me a longer cane. Now, if all doctor visits were that simple or all medical problems were that easy to correct, you probably wouldn't need somebody like me to help with your health care. But unfortunately, it's not like that. I pulled up a definition for healthcare advocacy, and basically it says it encompasses a wide range of professional activities with the goal of improving health and enhancing the effectiveness of the healthcare system. Excuse me. But let's go back and look at a little bit of the history. Healthcare advocacy has really been around at least since biblical times. I don't know if you're aware of the story in the Bible. It's both in Mark and Luke. It's about 4 men that have a friend who's crippled, and they put him on a mat and carry him to see Jesus so Jesus can heal him. And there's such a crowd when they get there that there's no way they can get up to Jesus so Jesus can see this gentleman. So they got the idea, there were steps to the outside of this house where Jesus was speaking and teaching and curing. So they went up on these steps and got up on the roof, opened up the roof, and lowered their friend on the mat down in front of Jesus. Now this is probably not the message that the Bible is trying to teach, but it also shows that healthcare, people trying to help others get the assistance they need for medical problems, has been around for a long time. In the United States, it's been around, probably dated back to about 1893, when a lady named Lillian Ward, who was a nurse, advocated and cared for immigrants in the Lower East Side of New York City. And she did this for years, and that resulted in the visiting nurse service. So it started way back there. A little later than that, about 1913, the American Society for Control of Cancer was established, which we know today as the American Cancer Society. So these type of advocacy organizations started. About that same time was the founding of the National Foundation for Infantile Paralysis. Again, what we know today as the March of Dimes. These things have been around for a long time, and they work as advocacy too. We have Alzheimer's Association members that are part of our Coalition on Aging, and currently I'm on the board for the JDRF, which stands for Juvenile Diabetes Research Foundation. We all advocate basically for disease states with these kind of organizations. But they're very needed, and what they do is they advocate for services for these patients, individuals. They advocate for research or funding for research, for care, even for just awareness, so people are more aware of some of these disease states, and also for understanding. Now the current field patient advocacy, healthcare advocacy. We go by many different names, but its roots started with the Patients' Rights Initiative. It started back in the 70s. And in 1972, JACO accepted the first Bill of Rights for patients. And then in the 80s and 90s, insurance sectors became larger and had more impact on health care and the kind of care that you could receive. Specialization of care increased. More and more specialists came onto the picture. Providers at that time, the primary care providers, oftentimes became kind of gatekeepers to these specialists. And health systems developed. We have Sanford and Avera both represented here. Those are the systems known in this area. They also expand into Minnesota and Iowa, I believe Nebraska too, some. But unfortunately, all this new and changes in healthcare made, unfortunately, navigation and access more difficult. These all developed without the input of probably the most valuable asset for it, and that was the patient. And so what happened is patients started going elsewhere to seek help in getting the health care that they needed. With the population and the culture that we have today, medical technology is advancing at breakneck speeds. And unfortunately, many of the people are not understanding the complexities and what is actually necessary to achieve this. People are living longer, as most of us are all involved with the seniors. They're living longer, and by doing that, they tend to have more opportunity to develop health challenges along the way and conditions that they may not totally understand. Oftentimes, these people or even their families don't have the medical background, the base of knowledge that they would need to deal with these kind of health issues, and that's kind of where we are born. Families aren't available, as Denise mentioned. We're a good example of people raising their families. They grow up here, and the families go elsewhere to seek their fortunes. Their kids do, and nobody is left here with mom and dad. Also, if they are left here, usually that age group is very busy with their jobs, their careers, their own families. They can't take time out of their schedules to go to doctor's appointments. They can't take time out of their schedules to really deal deeply into what's going on and understand so they can explain it to the parents. So that's kind of where we came around. Even though healthcare advocacy has been around for decades, as I mentioned earlier, it's just been the last few years that it has gained the momentum and the acceptance out there. You will find more healthcare advocates like me, or nurse advocates, patient advocates, on the coast. Just like everything else, it kind of starts there and moves inward. But there's also things like hospital advocates now, our case managers, that do some of the same things that I do. There's also insurance companies that have patient advocates that you can call in and get information. Some companies will have in their benefits program healthcare advocates, which provides kind of a peace of mind for their employees, that somebody else will go to the appointments, that they don't have to take time off work, so that the workers can be more productive. And yet their families are still taken care of. It's not always seniors that advocates deal with. They may be babies, they may be children, they may be, average working age people. But all these they're all kind of different. And one thing you have to be cautious of if you're dealing with an insurance company or even with a hospital, these are wonderful people and they do their best to try to help out. But oftentimes they are kind of within the constraints of the system that they are in. They have allegiance to the hospital, to the system, to the insurance company, and they might be limited on what they can provide. I'm a little different. I'm an independent healthcare advocate. I work with clients in their best interest. And if it means going to Avera for something and going to Sanford for something else or going to Mayo for something else, I can work in all these areas and help them to get what they feel is the best outcome. Okay, now you're probably all thinking, well, what specifically does she do? And as when I meet with clients and I meet with their families, basically it's easier for me to say there's 3 things that I don't do. I belong to 2 national organizations. I have belonged to 3. Currently I belong to 2. We both have codes of ethics, but on both of them we look at these 3 things. One is I don't offer second opinion. I don't make diagnosis. I'm not a doctor. I have a nurse and I have a lot of experience and a lot of life skills, but I don't make diagnosis. The second thing is I don't make decisions for my clients. I just try to provide them as much information as I possibly can that they can make an informed decision for what's best for them. Or their families together with my clients can make the decisions of what's best. And the third thing is, even though my background is nursing, I worked as a nurse, I don't do any hands-on. I don't do blood pressures, I don't do dressing changes, I don't do those type of things. I work more as a consultant. Some of the things I do is, as Denise mentioned, I go to doctor's appointments with clients. Especially you'll find with the seniors, they were kind of brought up in that area that, well, the doctor knows best. I'm not going to question him, I'm just going to try to do what he says. In this day and age, unfortunately, that's not necessarily the case. You need to ask questions, you need to get as much information as you can. And oftentimes people don't know what information they need, they don't know what to ask, or they may be afraid to ask. They don't want to rock the boat. And that's something as a healthcare advocate, I'm willing to rock the boat if it's in the best interest of my client. And so I have no problem asking questions and exchanging information with the physicians. I've got a lot of experience in that. As Denise mentioned, I was in the pharmaceutical industry for many years, speaking with doctors, all levels actually in healthcare. I spoke with pharmacists and administrators and nurses and doctors, and I even worked at one time as a neurology specialist. I was calling on clinical investigators. I was calling on university settings. So I've worked at all levels and I'm very comfortable knowing how to ask questions, knowing what to say and not to ruffle the feathers of a provider. And most of them are very accepting of me being with clients because then they know that the client is going to hear what they say. I've left several different items on the tables, and one of them is an article from BizNow magazine. They interviewed me back, and it was published back in January. And with that, they one of the statistics, and I've heard it was 17%, they found that 20% is all that a person remembers from a doctor visit. And if they get a serious diagnosis, if the doctor mentions cancer, for example, they completely shut down. They hear nothing. And of that 20% that the average person retains, only about 15% is really correct. So it's always good to have a second pair of eyes and ears in a doctor visit. And if the kids can't be there, that's where I come in. And even if the kids can come in there, a lot of them don't have the background, the expertise that I do to know the questions and the information that's needed. I also go to procedures with clients. Sometimes families are squeamish and they don't want to be at a procedure. And I'm very willing to do that. I go to procedures. I have also worked in family mediation. Oftentimes when you have a family member that is having health difficulties and doesn't know what their next step should be, the family isn't always on the same page. And I work with them so that make sure that everybody's informed what their options are, what to kind of expect. As we all know, everybody's different and everybody's going to react differently, but we can get trends of what probably will happen depending which way they go. So I do family mediation. Like I said, it's easier to say what I don't do than what I do. As Denise said, my background is very appropriate for this. I've got a Bachelor of Science degree in nursing. I worked in the hospital as a nurse. I've worked in long-term care as a nurse. I even taught a vocational program in health occupations. So I know a lot of different areas that are involved with healthcare. I have had many, many years in pharmaceuticals, as I mentioned and Denise mentioned, which really has presented me with the background and the knowledge that I need for this. When you're dealing with seniors, as most of you know, they may have a multitude of health issues, but they also have a multitude of medications often. And that can be very beneficial for them. It can also be a problem, and you have to be aware of what might be going on. So I have also completed a healthcare advocacy certification program. Now this is, as I mentioned, it's very new. Healthcare advocates really in this form have been around for maybe 10 years. And there is no national licensure like nurses or social workers or state licensure that nurses and social workers and administrators have to do. But we are working on it. Some of the leaders in this field are working on a national certification. I took a course just to cover areas that I wasn't familiar with. So I did have a better background and a better understanding. Kind of some of the social work stuff that you don't always get when you're a nurse. So that's what my background is. That's how I help people. And if anybody has anybody that they know that maybe could use my services, there's information on some of the sheets with my contact information. I've got business cards with me, or you can come up and talk to me afterwards too. I'd like to end with a story, and then if anybody has any questions, I'd be happy to answer it. There's a motorcycle patrolman that was rushed to the hospital with an inflamed appendix. And they knew he needed surgery right away, so they rushed him into the operating room, and the surgeon did a great job. Everything went well. When the patrolman came out, it was in recovery, he had this pulling and tugging at the hairs on his chest. And he thought, appendix is lower. I don't understand this. Did they do another surgery that I wasn't aware of? And as he got a little stronger and a little more alert in the recovery room, he thought, I've got to see, this is driving me crazy. So he pulled down his gown, and there were 3 wide strips of adhesive tape, the really sticky kind, on the hairs on his chest. And across it read, "Get well quick, from the nurse she gave a ticket to last week." If he had a healthcare advocate, that might not have happened. Anyway, does anybody have any questions? Denise?
Yvonne, what is your reception in doctor's offices or the various venues that you've accompanied your clients to? What's been the perception of your services as opposed to a daughter or other family member? Are people accepting of the fact that not all families come to appointments? Is it,
Actually, surprisingly, most of them are exceptional, and they will always tell my clients, "Oh, you're so lucky to have her," because they realize the communication problems. They realize that patients aren't getting the information that they need or remembering the information. So as a general rule, most of them have been very receptive. Some are a little leery, because I knew they've never had somebody come in like that. But as a general rule, it's been excellent.
Do you serve people no matter where they live, in their own home, assisted living, nursing homes?
Yes. I try to meet, oftentimes what I will do is I end up meeting the family member that hears about me and thinks that mom or dad or whatever needs some help, and I will meet for coffee with them. Explain what I do, go over, I have a service agreement that I have signed by me and by my potential client. And I go through that and what I don't do, and what they can fire me if they don't like my services, or I can step back if I don't feel that I'm providing the care or that there's just for some reason it doesn't work out. So I go through that, usually in an off-site, and then I try to meet the clients wherever they live. If it's in their home, if it's in assisted living, if it's in independent senior living, wherever the facility is, so I can see what their challenges might be. I do have a client now in a skilled care facility. I had her when she was an independent, and she has kept me on, and I still go to appointments with her. Oftentimes when they get to that point, they might be past what I can help them with to improve their quality of life. I picked up a client in a long-term care facility that was on therapy, rehab. And I started working with her then, and I kept her through the time that she went back to her independent apartment. So I go wherever I need to be. I office out of my home, so I don't have an office that they can come to. I think it's more important for me to go to them.
You know, with HIPAA and everything, you have to be careful. How do you, if like your patient or the person you're advocating for is demented, you know, and that's why the family is sending you, maybe they can't give consent. How do you handle all those things when you're...
Generally, when a person has dementia, somebody will have a medical power of attorney, and they can speak for them, and so they can sign the consent form in my service agreement. Even patients with dementia, generally there's a period of cognitive abilities when they can respond. That was one of the things that we covered in my course versus an uninformed client and an informed client, and how you handle when they are demented. You just have to get that stage of competency so that they do know what's going on. But I can also accept signatures from powers of attorney. And also, as far as HIPAA goes, at this point so far we are under the radar for HIPAA. It's a new organization, it's a new industry, so we aren't really required to use HIPAA, although I do have a release of information form that I have my clients sign that I can get information. But most of the time, if they go to the clinic will have their own for the client to sign, or the hospital has their own that their lawyers have done, and they want that signed, and that's fine too. Usually it's signed by both my client and myself. Yes?
One of the things I was just going to suggest, I think would be of mutual benefit to multiple parties, would be if, let's say you there's a client in a nursing home, and let's say the family lives in Chicago and part of in Sacramento and those kind of things. Obviously they can Skype for care plans and other things like that, but to have a local advocate who can see both sides of it and see what their loved one is actually getting and how they're responding to things and following through that, you would add a lot of goodwill to the resident, and you would add a lot of peace of mind to the family who can really identify what the real scoop is.
And that's very true, and that's another thing that I do provide. Obviously, it's with, and this can be a sticky situation, with the client's permission. I do send information to family members, so they are fully aware of what's going on. And I'm very honest with my clients, and I'll say, look, they need to know this and this. Oh, well, don't tell them that. And I kind of turn it around. Well, if something, as you were raising them, happened with them, wouldn't you want to know? And most of the time, I can get across to them that their children really want to know, they're concerned and want to make sure they're getting the best care possible. And so I do relay information from my clients to their families.
That would also validate that, frankly, that the facility is doing a good job.
Yes.
So it's not just a one-sided deal.
That's another thing that one of the services that I can do bedside sitting. If somebody's in the hospital or somebody, is in a facility, to make sure that they're getting the care that they're expecting to get. We are very fortunate. I took this course with somebody from California and somebody from the East Coast and stuff, and actually even my mentor was really surprised about assisted living. And it's important, I know, to keep people in their homes as long as possible. And many people don't want to go to assisted living, but just the fact that we have such beautiful facilities in this area, that, you know, I work with clients and scout out, get to know them, scout out areas that they might be content with. So I know most, that's why it's important for me to know most of you, so that I can recommend what works for them. Carrie?
What has been your top challenge since you've opened your business?
My top challenge is awareness, is getting people to know that I'm available. I can count on less than one hand the times that people just get, when I tell them what I do, just that aren't interested. Most of the time people say, that is a great service, it's very needed, but people just don't know about me. And that's what, that's why the article in Biz Now, and I've advertised in Biz Now, and I do volunteer work and stuff. So people are aware that there is a service like that. And I know my folks, I heard, from my mom for years, I don't know what we do without you. Because they don't know.
So what is the need? What's the theme mostly that you're seeing in the homes, or the need? Is it that they don't have a ride to their doctor appointment? Or what would you tell them if they said, I need a ride to my doctor appointment? What do you use for services?
When I started out, I said I wasn't going to drive people. I didn't want to get into that realm. But I checked with my insurance company, and one of my clients' family was in the insurance business, and they said that it's perfectly right. I don't do it all the time, but if they do need a ride, I had one client, and she used to say, I'll drive, and I would be a wreck until she got there. But she was going to make it to her appointment. And a lot of these facilities has cars that take them, and I will meet them at their appointments. But I do drive sometimes. That's just the way it works out.
I have a question, just because in the emergency room, a lot of the elderly people that we do see are usually more on the lower income side. So a lot of times it's because they just don't have the money to. So I guess the question would be, what if they have Medicaid? Is that something you work with, or how would you refer it if they can't afford your service?
Actually, unfortunately, as a new industry, there is no third-party pay. There's advantages to that for the fact, again, that I can do what's best for my client. I don't have somebody else saying, well, we won't cover that, you can't do that. So right now, mostly it's people that are financially well-to-do. It's a private pay facility. I do some pro bono work. I have helped different people that I guess it's the nurse in me. I can't just not help them out, and I know that they don't have the money to help me or to pay me. But unfortunately, one of my mentors is big on that you have to keep your business healthy as well as yourself healthy so you can help these people. And so, that she thinks that we don't charge enough for our services. And when you think of, I have one client that, it sounds kind of extreme, but close to saved her life. I mean, she was on multiple medications and was not feeling well and was not doing well and was going downhill rapidly. And now she's back going to the club and playing cards, and she went to Arizona to visit her sister. So, my services really can be very beneficial to somebody.
What would you say the range of cost is then? Do you charge per hour?
No, I charge per hour. My fee is $100 an hour. I'm trying to work out maybe a program for, I will do 5 hours for this, or I haven't got there. Starting out, it was just easier to charge an hourly basis, and I try to be very fair. I break it down into 15-minute increments, and if I'm there 20 minutes, I'll charge them $25, like that. But unfortunately, I have to keep the business going.
How do you keep track of their med lists and keep those up to date? Do you
I have
copies
files.
of their office?
Yes, I have files, and then I also get, when we go to the physicians, and I know most of the time you'll get a summary, a visit summary. It will list all the medications, and I keep that. And I'll go through their medications and see. I have found that there's ones that they may be taking that aren't even, the doctor's not even aware of. So that's another duty that I perform.
So do you help them at all set up, like sometimes home health nurses will come in and help them set up their home medication. Do you ever help them with that, or not really?
I really can't.
Okay.
Because as a healthcare advocate, I'm not licensed as a nurse, and I have liability insurance just like you people do, but mine is more errors and omission. It's stuff that I tell them that maybe I'm misinformed, or that I forget to tell them. I can't actually, it drives me nuts, because I've had so much experience in pharmaceuticals, and I know, but that's one thing I don't do. But I do set up, home health and get somebody that really knows what they're doing that can help them.
Sounds like there's no real general scope of practice.
It's very, very, and some people work strictly with insurance problems in healthcare advocacy. Some people do like I do, and it's more of the hands-on, the working and establishing a relationship with the clients. Some people, like I mentioned, with these organizations like the Alzheimer's Association and that, they work in those organizations as far as laws and changes. Hospital safety, advocates work with hospital safety issues and stuff like that. So it really is, it's a kind of a catch-all term. Anybody else?
Let's give a round of applause.